amazing vista you have there.
I've been trying out to see whether virtual vitamin D exposure is adequate or supplementary to the real thing. So far, it's too soon to tell.
Let me know how those lab values go.
All right, it looks like we have a good number here. All right, so like I said, these are quick. First thing, just a quick thank you and continued appeal for everybody who's been participating in the interview process. We have already gotten positive feedback from the candidates that interviewed earlier this week about the level of resident participation. With all interviews now being virtual, I think that many places have either minimized or eliminated the resident contact, and several candidates this week specifically mentioned that they really enjoyed and appreciated all the opportunities to connect with our residents, whether the night before or the day of. So thank you and great job, everybody who's been helping out so far and everybody who is going to be helping out next week and on any of the future dates. Especially as we're all experiencing Zoom fatigue. A special thank you for everybody's willingness to participate. And then the second other quick announcement is we wanted to make sure everybody just saw John Medvard's email from last week, I think it was, end of last week, just about communicating critical findings, when to use the macro communication, when to use the critical yellow, orange, red, etc. If you have questions about that, the email was sent on November 6th, if you want to refer back to it, or we can give you guidance too. There's some gray area on this stuff, obviously, too, but I think it's nice to have some guidelines laid out. And that is it for me. Thank you again to everybody for your ongoing participation, and enjoy lectures today. Thanks, Nathan.
Yeah. Okay, so hopefully my screen should be coming across. And is that visible?
Yep.
Yep.
Awesome. All right, so you must suffer me again, this time on head trauma. Although, who knows, maybe I'll sneak some informatics in here somewhere. So I'm going to start by, I'm not going to go through the really basic stuff because I think those that haven't seen it already shortly will, and will get loads of exposure to the common subdural, subarachnoid hemorrhage, and over at Harborview. And there'll be lots of references there and lots of opportunities to learn about those. So I'm going to focus on stuff that's a little bit less common than that, but hopefully not get too far out into the weeds. So the first thing that may not come up every day, but as you move into being an attending and you start to interact, like at nights in Harborview with people who might be asking you questions about imaging in terms of when it should be done, it's important to know that there are some systems out there for basically guiding clinicians as to when they should get imaging. PCARN, which is the pediatric system, is used, I think, quite well at the academic pediatric practices. It's divided into those older than 2 and less than 2, and basically, if you meet some of these criteria, you're then a candidate for imaging. And you can see that they bear a lot of similarity with the adult systems in that some of the same data elements are used to determine when you need imaging or not. And a lot of them are pretty basic, you know, vomiting. In the adult population, your age is a big predictor, just because it can be harder to detect in some older patients. And then basically signs of significant trauma, some evidence that there's a really bad injury, Glasgow Coma Scale all kind of play a role. And the advantage of the pediatric system is it comes with some very helpful visual cues as to what they mean. Still not quite sure what that means, but you know, probably bad car accident. So to start with some of the basics that we pretty routinely mess up, here's a diagram of the scalp. We frequently refer to subgaleal hematomas, and I just want to refresh people's memory of the anatomy here. So you have a layer of skin, and then deep to that you have some adipose, and then a layer of connective tissue, another layer of connective tissue, and then the pericranium. And so particularly in the middle of the head and going out away from midline, there's this very dense layer of connective tissue or aponeurosis called the gallia aponeurotica. And this is a really, really tough band of tissue. And if you get a bleed that's deep to that, it basically extends along the calvarium in this crescentic shape. Not infrequently, we see people with hemorrhage in their scalp that's actually superficial to that and forms like a rounded collection in the scalp. So those are probably not subgaleal hematomas. Those are just little bits of bruising and hemorrhage out in the soft tissue. Not a huge deal, but it's just clear to communicate exactly what's going on. Also, the surgeons have told me that they like when we call something a hematoma that we keep that term just for true hematomas, i.e. collections of hemorrhage, not just bruising or some soft tissue stranding. Once you get a little bit deeper, you have the inner layer of the calvarium, the diploic space, and then the outer table diploic space, and then the inner table of the bone. And then below that, you've got the dura mater, and I think I've got a diagram which is a little clearer. But you've basically got a couple layers of dura, and then the arachnoid mater, some subarachnoid space with a bunch of bridging vessels and some vessels traversing the space, some vessels coursing throughout the space, and then the pia that is intimately associated with basically the surface of the brain. So I just wanted to highlight here that the dural venous sinuses, as their name suggests, are actually in the dura. So you have a split between the periosteal portion and the meningeal portion of the dura that form these vessels. So epidurals are definitely not the most common thing we see at any of our sites, but they do crop up from time to time. They're basically convex collections of blood in the epidural space, right? So out superficial to everything here next to the bone. And we usually think of epidurals as arterial, and about 60% of them truly are arterial. But there's also a good fraction of epidurals which are non-arterial. And they can be caused by a variety of different causes. They can be from venous sinuses, from injury to a venous lake, an injury to a diploic vessel, or the arachnoid granulations. So there's an interesting article out a number of years ago looking at surgically confirmed causes of non-arterial epidural. And this is a few of those cases. So this was an injury to the superior sagittal sinus. And these ones up near the vertex are particularly well evaluated in coronal plane. And you can see here that the collection of blood extends across the falx, or I should say it's superficial to the falx. But it's basically crossing midline, which is your clue that it's epidural. If this were a subdural, right, it would extend along the bone. It wouldn't be convex usually. And then instead of going across midline, it would actually extend down along the falx. So just to make sure you know the visual clues here. And then another cause, this was an injury to an arachnoid granulation, which is why you see a bunch of CSF mixed in with it. This was a diploic vessel that they determined at surgery that had caused this. And these we see pretty frequently over at Harborview. Basically, whenever you have a calvarial fracture that extends across the dural venous sinus, these are particularly easy to see on the post-contrast or CTA images that they often get. If you see any kind of non-enhancing collection here, or on the non-contrast, if you see a very thin collection of blood here that's superficial to the dural venous sinus, that by definition has to be epidural, right? We just talked about the superior sagittal sinus being displaced downward by the in this image, right? So if it's superficial to that, it has to be in the epidural space. Same exact thing is going on here, superficial, and this is a venous epidural. And if you look, those can be very thin, and you will often see them over at Harborview. This is one that also you see pretty frequently. I feel like the cases that I see these most frequently on are the like really bad car accidents, really bad high mechanism trauma, where they've got a whole bunch of other things going on, but they also have this collection of blood here, which is kind of convex, just anterior to the tip of the temporal pole. There was a large study of these done, and by large, I mean radiology large, so like I think 50 or 60 cases. And they basically followed these for a period of time in the hospital and got multiple rounds of imaging, and basically concluded that these were probably for an injury to the sphenoparietal sinus, and that I think only one out of the something like 60 cases progressed at all, and I think it was not considered clinically significant, even this one case that did enlarge a little bit at follow-up. So these have a very indolent course. Another form of epidural, venous epidural hematoma, kind of a characteristic location. And to refresh your memory on what the sphenoparietal sinus is, it's basically just a superficial vein here that's feeding into the cavernous sinus. Contusion. Contusion we see a lot at Harborview, usually from high mechanism trauma. And basically it's an area, it can be hemorrhagic or non-hemorrhagic. Frequently it's hemorrhagic, and it's an area of brain that's basically been injured and is now bleeding. And unfortunately, it can be a little challenging to determine if it's truly a contusion or whether it's subarachnoid hemorrhage. Subarachnoid hemorrhage can have the appearance of contusion because it can sometimes go deep down a sulcus and just look like it's kind of hanging out within the brain parenchyma itself. The best clue that I have is if you see some edema surrounding it. You do not see that with subarachnoid hemorrhage in a sulcus. You only see that when there's basically injury and irritation to the surrounding brain parenchyma by the area of hemorrhage. So, and you know, sometimes you're imaging so acutely too that even if it was a little bit of blood that was within the parenchyma, it hasn't had a chance really to develop the edema around it. So sometimes this is really only gettable on the follow-up. And often these will increase in size on follow-up. There are definitely areas that are more prone to contusion than others. The bottom of the frontal lobes here in this really state-of-the-art graphics from when I was at the age of 5 in 1988, but I thought it was a pretty clear articulation of where contusions happen. So floor of the frontal lobe, the anterior temporal poles here. You also get it in areas where if there's a shear rotational injury or rotational movement right next to something that's fixed or rigid, so like the falx, which is a very dense band of fibrous tissue, the brain parenchyma can beat up against that during the acceleration, deceleration, or rotation, and basically get injured and bleed. So right next to the falx, corpus callosum, and then another area next to the calvarium is in the occipital lobes, right up against the tent as well. And then you can have it more centrally next to the cavernous sinus and clinoid processes. So diffuse axonal injury is the more commonly used term, although people in literature are trying to change the name to traumatic axonal injury. The reason being that diffuse axonal injury is the name implies that you get injury kind of diffusely throughout the brain, and that's usually, well, it's often not the case. That you get kind of more distribution of injury in one region than another. So hence the name, the suggested name change. So basically, this is caused by rapid acceleration, deceleration, or rotation. and you get shear and strain forces that injure axons and lead to swelling or disconnection of those axons. And you can get some hemorrhage associated with it, although you don't have to. And the findings that you see, this is a non-hemorrhagic case where you can see that there's kind of some patchy hypodensity. Hopefully this comes through across Zoom. Maybe it, yeah, I think it does. Anyway, there's some very subtle areas of hypodensity in here, which would show up on a diagnostic monitor. That are areas of edema on imaging. And I don't think these are the same cases, which is why the distribution is a little bit different. And then on diffusion weighted imaging, you can get corresponding foci of diffusion restriction. And on FLAIR or T2, FLAIR T2, you can get areas of hyperintensity or edema in areas that are prone to TAI. Susceptibility weighted imaging can show it quite well because it's quite sensitive to blood products and can often show dramatically increased extent of injury over CT. Usually if you can see little foci of hemorrhage in the brain parenchyma on CT, it means that it's a really bad case. Because by the time you get to SWI or GRE, the injury is just found to be much more extensive. And here you can see how the name diffuse doesn't really summarize this well. It's a bit frontal predominant in this case. And here's another SWI image just showing some scattered areas of blood products. Again, usually multifocal and some more diffusion restricting foci. If it's really bad, you can definitely get involved in the corpus callosum and the midbrain or brainstem. You can even see a little bit of cerebellar injury there too. I just wanted to touch on mild traumatic brain injury because particularly as you start to talk to clinicians outside of the, well, sometimes in the ER, but outside of like neurosurgery and neurology ICUs, mild traumatic brain injury is it's been very prominent in the news. It affects a lot of people. There's a lot of different causes of it. And there's a lot of concern that this is leading to dramatic effects on the population in general, just because of the extent. So out of the military, there's a large proportion of people affected. About 30% of the 1.6 million US military members who've been deployed recently have some form of mild traumatic brain injury. And this is a quote from a recent review article. Basically said, in assessing long-term outcome, there is essentially no role for conventional CT and MR imaging. And I mention this just because it's not uncommon to get asked, like, well, what can we do to assess these cases? What can we use to prognosticate? And conventional imaging just isn't providing the answers that people would hope. It can rule out other things that might be happening, but in terms of trying to prognosticate or evaluate mild traumatic brain injury, it just doesn't have much utility. When you look at the studies that have been done, looking at larger populations, there's a number of interesting observations. People have noticed that in the subacute setting, you can get some cortical thickening, which is thought to be like a little bit of edema from the actual traumatic injury. That eventually progresses into some chronic cortical volume loss. And there's been a note that you can often see this more heavily in the precuneal region of the brain as opposed to elsewhere, and also in the middle frontal gyrus. Another study looking at MTBI showed that you can get chronic caudate volume loss, and it was a study on boxers showing that there was actually a dose-related effect. The more severe injuries in boxing that somebody had, the more caudate volume loss they had. You can also see some chronic diffuse volume loss, particularly with quantitative measures. even with a single mild traumatic brain injury episode. Looking at more advanced techniques like DTI, you can get a decrease in fractional anisotropy. And for those if that's not on the tip of your tongue exactly what that means, the way I think of it is anisotropy, right, means that water molecules are restricted in their movement. If they could move isotropically, they could move in all directions equally. So if you've got a decrease in fractional anisotropy or a decrease in restriction of that movement, it means that water can now move around more freely, which is bad, right? Because usually the water is being restricted within white matter tracks by the axonal tracks themselves. So that implies that there's some injury to the neurons and axons themselves that's allowing water to move around more easily. You can get memory and attention changes on fMRI. On magnetic resonance spectroscopy using protons, you can see a decrease in NAA. NAA is a marker, or N-acetyl aspartate is a marker of neuronal integrity, and an increase in choline. And so people have looked at, whether advanced imaging in traumatic brain injury is a potential solution to these issues. And conclusion from a recent review article was that there is insufficient evidence supporting routine clinical use of advanced neuroimaging for diagnosis and or prognostication at the patient level. Meaning that you can see some of these changes, like what I've just mentioned, on a population level, but when you narrow the scope down to an individual patient, all the benefits that you gained in statistical power by looking at a huge population have now been taken away, and it's very hard to draw conclusions on a case-by-case basis. And that was a Class 2B recommendation. So I was just going to touch on some traumatic brain injury complications. And I think you guys all have access to the chat, and actually there's a message that, great. So feel free to chime in with these. These are meant to be interactive, or at least give you a chance to think through them. So this is a trauma in a patient that happened about a month ago. This is usually seen in kind of pediatric or young people. And any ideas what this might be? Just filling in the chat. Hygroma is one thought. Traumatic brain injury. So Hoiwan, I think you're talking about the encephalomalacia there, I think. Pseudomeningocele. Okay, so that's something to do with the fracture that doesn't heal. Excellent. Yeah, exactly. So you can see that there's an osseous defect here, right? And there's obviously some sort of underlying injury here, right? You can see that there's encephalomalacia, the brain parenchyma here is injured, it's thinned, it's hypodense. You can also see there's ex vacuo dilation of the ventricle, meaning that there's been some volume loss in this region that's allowed the CSF to take up more space than it usually would, and the osseous defect. So this is called a growing fracture. And basically somebody will get a fracture. They may have some underlying brain injury as well, but there's like a dural tear, and the pulsation of CSF can actually protrude either the CSF or the CSF and meninges into the fracture there and can keep it from closing. They're also known as leptomeningeal cysts, which is kind of a misnomer. And you can get this expansile scalloped area of CSF extending into the site of the prior fracture, and it represents an underlying dural tear. And they can be slowly progressive. So, you already on this image, you can see, right, that it's got a nice smoothly marginated, corticated margin there, and it's not going to heal over there. So these can sometimes go on to surgery to close them. The other location I've seen, aside from the calvarium like that, is actually the temporal bone. And again, it tends to be younger patients. And they can get some neurodeficits from the Mass Effect. All right, here's another case. So this is somebody who had a remote motor vehicle collision and has a problem with deafness. And these are 3 axial MR slices through the midbrain pons and kind of lower pons or upper medulla. And chime in when you have some ideas. Nice. Superficial siderosis. Exactly. So you should be able to see that there is a linear hypointense coursing along the surface of the brain and brainstem and cerebellum on all these slices. You can actually see it extend out along vestibulocochlear nerves. And so this is a common cause of hearing loss post-trauma. There's some other causes too, but in terms of direct injury to the bones of the middle and inner ear. But hemosiderosis doesn't always have to be from trauma. But it's basically, it represents recurrent hemorrhage. So sometimes you'll find that somebody who has an AVM will have some siderosis. And it doesn't always have to be in the brain either. They can have a lesion in like the spine or along the cord that's periodically bled and will lead to hemosiderin depositing pretty extensively throughout the neuraxis. And unfortunately, there's a like cytotoxic effect of the hemosiderin and its associated radicals that leads to some neuronal injury, which is why there's the deafness reported with this. Basically, the microglia along the vestibulocochlear nerve are particularly susceptible, and so that's why they often report deafness as one of their symptoms. And you know, if the underlying etiology isn't particularly obvious, or they don't have a history of trauma and don't have an obvious lesion, you may have to extend imaging throughout the neuraxis to make sure that you've actually done a sufficient search for the underlying etiology. All right, this is a patient with altered mental status. Any thoughts? Use edema. Subarachnoid. Excellent. It's just no fooling you guys. So just be careful with this one. It's one that we occasionally miss. It can be subtle in its early stages. The things you should see here are basically all the dura looks a bit too bright. The reason why this is called pseudosubarachnoid is obviously because it has kind of a similar distribution to what subarachnoid hemorrhage would look like. But the other things you should notice are that there's very little space, right? The sulci appear all effaced or almost entirely effaced. The ventricles are very, very tight. And then there's a lack of differentiation between the gray matter and white matter. You can't see the basal ganglia, the thalami, and you also can't see the cortex. So diffuse cerebral edema, this is usually some sort of cardiac etiology, like they had an arrest in the field, underwent CPR or something, and are coming in and now are diffusely altered, and they have some concern that there could have been an episode of ischemia. And just keep an eye out for this because it can sneak up on you. This might qualify as getting a little out into the weeds. This is a somewhat unusual diagnosis. I actually had my first case of this when I was at Northwest as a resident, moonlighting. It was a patient who came in with their first seizure, and it looked just like this. So these are sometimes called clocks, but it stands for cytotoxic lesion of the corpus callosum. Basically, it's an area of diffusion restriction or flare hyperintensity in the corpus callosum, and there is a laundry list of causes. It can be from infection, it can be inflammatory, and one of the possible etiologies is trauma. So somebody who's had subarachnoid hemorrhage or a diffuse axonal injury can get a lesion here. Basically, the subarachnoid hemorrhage, because of the toxicity we mentioned a few minutes ago, you can get a focal lesion here. So just recognize that just because it's diffusion restricting doesn't mean it necessarily is an acute infarct. There's a variety of causes of this lesion in this location. Here's another case, and I've got a second image, but I'm going to give people a chance to look at this one for a second. So any ideas? All right, Richa. Yep, great. Got it. So as you would expect, so to start with, this is an axial non-contrast CT slice through the kind of upper brain. And you can see here that the superior sagittal sinus is a bit too bright. And on a post-contrast study, you can see that there's a filling defect in the superior sagittal sinus. You can see it actually anteriorly as well as posteriorly. So dural venous sinus thrombosis, about 40% of fractures through a dural venous sinus or across a dural venous sinus have a dural venous sinus thrombosis. The petrous temporal is one of the areas of highest risk. You can also have associated complications. So you can have a venous infarct associated with this. Chronically, you can have issues with drainage. Here on this axial CTV, I think, you can see that there's a filling defect here in the transverse sinus, and that you can see that there's some reconstitution of the sigmoid portion. And then you can see the traversing fracture here. This is one you will see pretty frequently at Harborview, just because of the number of calvarial fractures that we get there. And it's just another caution that whenever you have a calvarial fracture, one of the things that should be on your checklist is just to look for an epidural, because there will often be a small collection in the epidural space adjacent to this, and dural venous sinus thrombosis is another common complication. And I just wanted to mention this because it's an easy thing to struggle with in terms of whether something is dural venous sinus thrombosis or an arachnoid granulation. They can look somewhat similar. An arachnoid granulation is usually it's coming from the edge of the sinus, and they're usually very rounded. So if you see something that's pretty longitudinally extensive within the dural venous sinus, either that extends through multiple slices, or in the case of the transverse, like here, extends for quite a distance here, it's not an arachnoid granulation. Arachnoid granulations are kind of focal and rounded. And they don't always occur in these locations, but they do typically tend to affect the transverse sinus, the sigmoid sinus, the superior sagittal sinuses quite a bit. And they will follow CSF signal also. And you may also have some associated osseous remodeling. You can see how they're protruding here into the bone. And usually you have more than one, although. All right. And since, at least in my day, they were always encouraging speakers to incorporate some physics into their talk, I feel the obligation as well. And this happened to me on Sunday. I got a call from an eager neurology resident who had an outside head CT that had a focal focus of hyperdensity in the basal ganglia, and wanted to know what it was, because the outside head CT red basal ganglia hemorrhage. And it was just this punctate hyperdensity without any surrounding edema, as we mentioned for contusions. And, you know, it's a basal ganglia in an older person, so it's a common site of calcification. And at least in this case, it was so focal. The density was like 90 Hounsfield units, which is getting kind of above your typical kind of hemorrhage ranges. And apparently was looking fantastic, and it already had, I think, a follow-up for it, and it was identical. And again, there wasn't any edema surrounding it, so I was pretty happy just calling it calcification. But if I had been at all on the fence about it, this is a technique that could potentially help you if you have a dual energy scanner. So basically, this is conventional CT here on the left. This is a calcium masked image, and then this is a virtual non-contrast image on the right. And so basically using dual energy material decomposition, which if you haven't encountered, I'm sure you will shortly with the physics team or perhaps in body. But basically, mathematically, you can create a virtual non-contrast. And you can see that this area of hyperdensity on the conventional image in the corpus callosum here, it's actually got two parts that show up on different, on each of these. So this area on the patient's left persists on the versatile non-contrast and actually doesn't show up on the calcium mask. So that's hemorrhage. The part showing up on the calcium mask here on the patient's right is actually calcium, and you can see that it drops out on the virtual non-contrast. And just to elaborate a little bit on dual energy imaging in neuro, we don't do tons of it. We do use it for people who have just undergone angio and were worried that they could hemorrhage. And in that setting, you've got frequently some contrast, which is extravasated. And so you're trying to distinguish whether it's all contrast or whether some of it could be hemorrhage. And so we'll make these virtual non-contrast images. And you can see here that this is windowed pretty aggressively, which I think is appropriate for VNCs and neuro. The hemorrhage that you see on these is usually not as contrasty. It doesn't stand out as much as it does on conventional imaging. So if you window somewhat aggressively and you see nothing, great. You know, then it's probably it's not hemorrhage. But if you see something subtle, I would probably err on the side of calling it, because the cases where I know there has to be hemorrhage there, or they've had multiple follow-ups and it's definitely continuing to bleed, they tend to be pretty subtle on the VNC. So just a word of caution. Here's another case showing this area of hemorrhage here. It's not showing up on the calcium mask. Hyperdensity here on the conventional imaging. All right, before I get to that, I just wanted to touch on a couple things. Let me change what I'm sharing here. Does anyone have questions about the trauma portion there?
Hey, Nathan, I have a quick
Yes.
question. Do you have a Hounsfield cutoff you use when you're evaluating dural venous sinus on a non-con head?
Yeah, that's a good question. So on a non-contrast head CT, yeah, I mean, some people, it depends on the patient. So a lot of factors play into it, right? Are they anemic? How long has it been since the clot formed? You know, has it had time to retract and condense, and where it usually increases in density a bit, or is it really acute and it just clotted? Those kind of all play into it. If it's a usually clot, I feel like is in the 50 to 70 range. But there is some variability. I try and use the patient's other vessels as internal controls. So I'll often try and window so that I can see at least one or multiple of the vessels pretty well, and then I'll compare that density to the area that I am concerned about to see if I can find a difference. Anyone else have some other other ranges they've seen used. That answer your question?
Yeah, thanks.
I've got a question about doing non-con head CTs on, particularly at UW, because I think we'll probably do less of them, but non-con head CTs on patients who have had contrast for whatever reason, and we're following something up like later in the night. Do you have any tips on how to navigate, like determining if there's some new hemorrhage versus if you have contrast staining, or like what techniques we can maybe use, or scanning protocols to try to delineate that out?
So just make sure I got what you were asking. Somebody who's had contrast for one reason or another, maybe because of some neuro problem or maybe entirely unrelated, and you're trying to evaluate a site of concern and figure out whether it's contrast or hemorrhage.
Yeah, because we know that they're going to have a short interval non-con head CT, and like, how can we avoid this quandary of like, is this hemorrhage or contrast staining, when we know that the patient's going to have a short interval follow-up?
Yeah, so I mean, if it progresses, you're good, right? It's clear. But if it doesn't progress, then if it doesn't enlarge, then it's unclear whether it's just hemorrhage that's stable or whether it's contrast. There are a number of dual energy scanners at the UW. If you're particularly worried about a specific patient, you can certainly request or protocol it, or call the tech and tell them that you want that patient to go for dual energy head CT. Over at Harborview, the neuroangio cases, I think the immediate post-angio, post-intervention head CT is, I think, always now a dual energy one. So the text will certainly accommodate you if you, or will almost always accommodate you if you ask. But that requires that you know about it beforehand. Other than that, edema is helpful. If you see edema in the brain parenchyma, change in size. It can be really pretty challenging as you are no doubt encountering. Any other questions? All right, you guys had me talk about Universal Viewer a couple weeks ago, and I just wanted to follow up. There was one comment that I actually did have a solution for that I didn't make it to. Somebody had asked, is there a way to make a work list of something in Universal Viewer so that, like at Harborview overnight, I can try and keep track of patients, matching some search criteria. And I'm not sure this is going to work amazingly well, but it might. Give it a try. There is a way to, so you can, make an advanced search, like you can say today and yesterday, anyone who had maybe some sort of head imaging by CT. I think this will give us some results. Right, so you've got a search here for CTs of the CT or CTAs of the head. And you obviously don't want to plug that in every time. You want to be able to quickly reference it. So if you go up here and you right click on this tab, you can say save search as. So let's say, call it CT head. And now you get a tab with CT heads. And you can sort it by ascending date or something, if that's helpful. So I'm not sure this necessarily solves that problem, but it might help a little bit. And then to get rid of it, you can delete it at any time by just going up here. And you can either refine it by clicking edit and changing your search parameters. Changing your search parameters here, or you can just get rid of it altogether by right clicking and hitting delete. All right, so I wanted to throw that in there. One other thing, I came to you a couple months ago about pulmonary nodules, So there is now, as you hopefully saw in the email, there's now an incidental pulmonary nodule macro that's been distributed to the site macros. We took a lot of feedback, and I hope you find it useful and easy to use. There we go. So if you're in this little merge field, or sorry, not merge field, but selection, you can now see that all the different options. So we combined both the non-solid and the solid macros into one. And there was a request that the approximate follow-up be included in the field in the label here, so you can see what the approximate follow-up is. And actually, some of these you'll now note include recommendations for follow-up and clinic numbers. So the hope is that this will facilitate patients making it to the appropriate clinic for follow-up for the appropriate lesion. And we've already had some clinicians email back that patients have made it to their clinic because of this. So excited that this may be helping people get the follow-up they need. Stop sharing the screen. Any questions about that? All right, and then go along with everything else. I thought I would, since physics gets represented, I feel like other non-interpretive skills need their day in court. Does anybody know what IHE stands for? All right, so it's integrating the healthcare enterprise. So this is an organization that promotes integration of HL7 and DICOM. And they have a number of what they call profiles for different activities. Basically, these guys try and create a roadmap of what happens for different tasks. Like, say you have an outside record that needs importing into PACS. They have a diagram with who's supposed to do what step of that process, who gets the CD, who scans it in, patient matching into your master patient record, and how that gets incorporated into your workflow. The reason this is necessary is that when a business wants to design a solution, they need to know how this stuff commonly works in clinical practices. And so having a structured layout of all the different steps and how it's usually achieved at an institution is very helpful for them, because then they have a better understanding of what solution what problem they're trying to tackle and all the various players. Begs the question of, what does HL7 stand for? Anyone know? Put in the chat. All right. Health level 7. So this is how information, non-radiology information for the most part, moves around the hospital. So when you have a patient that's admitted to the hospital, or when they have a laboratory test resulted, or when they have a radiology exam resulted, eventually an HL7 message gets created to communicate to different informatics systems within the institution. And the way it used to be done is with HL7 version 2, which looks like this, and was created in a bygone era of faxes and dial-up modems. And basically, each of these fields numerically, so the first field, second field, third field, or whatever, which is separated by one of these vertical bars, has a specific meaning. And you can kind of extrapolate what those might be just looking at some of these, like, here's a patient name, or actually this might be the ordering position. This is some sort of address. Anyway, they've all got a specific name. They're all delineated by these bars. It was, it was a good start, but it's not a very elegant system. Version 3, I think, is now XML, which is a more kind of structured and modern way of encapsulating data. But when people talk about HL7, it's basically a system for messaging little bits and pieces of data, moving from one system to another to keep all the different informatics systems within the hospital up to date and with the information that they need. That was a hard one. What about DICOM? No one? We use DICOM images every day. All right, I got one response. Exactly. So it stands for Digital Imaging and Communications in Medicine. It was started in the 1980s. Basically, the challenge was that people wanted to gather all these imaging studies or images of people, but they needed a way to make sure they didn't get mixed up. You can imagine if you get a camera from Best Buy and you want to take, say, images of people's moles and keep track of them on your computer as part of some sort of patient management routine, it would be very easy to mislabel them or to get folders mixed up. So this is DICOM is basically a wrapper that goes around the image and encapsulates a whole bunch of data about the patient, who ordered the study, why it was ordered, how it was performed, where it was performed, all of this image pertaining to exactly who the image is of and how it was generated and why, all wrapped up with the actual image file itself. The reason I use the term wrap is because the actual image is stored in a number of different ways, and DICOM does not specify an image storage or compression mode. You can store it as like a PNG or a GIF or a JPEG or just something completely uncompressed like TIFF. And you put this DICOM wrapper around it with all the patient's metadata just so that it doesn't get confused or mixed up with anybody else's images. And this actually was an amazing innovation that has transformed radiology. And it's, interestingly enough, a problem that has come up again in the past 10 years with other workflows where people are taking images, dermatology clinics or ORs where they've got various imaging sensors that are taking pictures through endoscopes or whatever, and they're trying to store them for later use. The companies that are making these systems don't initially start with very elaborate techniques for storing the data, but need a way to make sure that their images don't get mixed up. And so actually DICOM has been extended to incorporate other, quote, visible light techniques to store other types of imaging data in a robust fashion. And actual DICOM, we don't have to go very far into this, but basically you have a tag for a piece of metadata, right? So you have one of these elements for every single little bit of data that you want to store about the patient or about the exam. And there's basically a numerical code, which has a group and an item. And if you look up in the dictionary for DICOM, what this individual set of codes means, it will tell you it's a patient name. So actually it doesn't say patient name anywhere in the file that's written out. It just has this little code, and based on the dictionary that comes along from the DICOM organizational body that this is supposed to be a name. And so you've got loads and loads of these ones that are specified. The problem is that sometimes companies want to store things that aren't specified in DICOM. Maybe they have some exciting new technique and they've got some parameters to it that they need to store. Or maybe they're just feeling lazy and they want to store something that there is a DICOM field for, but they either don't know it or for some reason they don't want to store it in the standard field. They can put it in a custom field, which they can. There's some ranges of these numbers that people can use for other purposes. That's one of the flaws of the system, is that people can create custom areas. All right. So that's all I have. I hope that was helpful. Thanks for all your hard work, particularly during these challenging times. Any questions? Anything I can help with? All right, well, thank you all.
Hey, Nathan, it's Jerry.
Hey, Jerry, how are you?
Take the baton from you.
Yes, please.
Good. I see we're not really set up to do polling. At least I don't see it on my screen. Do you know? Who
I
owns
think
this?
there is a polling. Oh, it only appears on one of my computers for some reason.
You need to
You
be
may have to
listed as
log
a
in.
host, so let me add you as a host, and then you'll be able
Okay,
to poll.
thanks. Because I actually set this up to ask questions. There, I see it now.
Great.
Great. And so let me just practice this once. So if I have a slide that I want, so that's a previous poll. Say, Marcus, do you know, do I need to have the question set up in advance for the poll?
There, I can edit them on the fly here. I typically have A, B, C, D, E options set up.
Yeah, I think that'll work. A, B,
Okay.
C, D, E options, and then so for a given slide,
Mhm.
Actually, I'm looking now. I've got 1, 2, 3, 4, 5.
Okay, so you can just reset the poll at the end of each question. Hold on just a moment for me, and I'll get it set for you.
Okay. We'll see how it works. Always good to try something new. And let's see here. Let me start sharing my screen. Hopefully folks can see my PowerPoint now. I am going to try and going to the presentation, to the slideshow mode, and see how that works.
If you launch polling now, you should just see one question with A, B, C, D, E choices.
I do.
Great.
People just have to transform in their minds A, B, C, D, E to 1, 2, 3, 4, 5. I think I can handle it.
Oh, I can fix that.
And can you just see my title slide and not the other slides?
We see the presenter view, so we can see all of your future slides.
You can see all the slides.
Yeah.
Okay, so let's end the show there for a second. So how do I get out of the presenter view, I guess?
If you click slideshow at the top.
At the top.
Yeah.
There we go.
Um,
So I can just custom show, is that what I want? Or place in current slide?
Try that.
sure.
No, you probably can still see all my slides, is that right?
Maybe use slideshow, that button to the right.
Oh, where was it's not liking it. Save from current slide, a new slideshow. Sure, that's probably working, right?
That works.
Okay, we'll go from there. We'll give it a whirl. Okay, hi everyone. I'm Jerry Jarvik, I'm one of the neuroradiology attendings. And let me see if I can bring up the participant list. So why don't we do this way, that I'll just go through the slides. I've got some questions that are embedded within the slide deck. And when I get to the questions, I'll launch the poll and you can answer the questions. We'll see how that works. And if anybody has any questions along the way, please feel free to interrupt. Now, can you see the participant list in the chat box, or are you just seeing my slides? I'll assume that you're just seeing the slide deck and that the other stuff isn't covering stuff up. So what I'm going to be talking about today is spine imaging. And since I pretty recently gave a review of degenerative spine stuff, that was just a few months back, I thought I would focus today on intradural lesions. I also gave a talk on extradural spine stuff a few months ago. So hopefully you haven't seen these slides too recently. And so this is just going to be a case-based presentation. So we'll see how far we get. So starting off here, we've got a 26-year-old male, headaches, visual problems, and back pain for years, and a family history of renal cell carcinoma. Great, and thanks, Richa, that you can just see my slides. So here we've got a couple of sagittal images. We've got on the left sagittal T2, on the right sagittal more or less T1. It's probably closer to proton density. Let you just look at that for a second. Think back to the history I just gave you. Here's an axial image of the head that we can see. I feel like I'm just talking into a vacuum here. So this is the same diagnosis as the other patient, but a different patient. And this shows post-contrast T1 weighted images. In fact, who was I reading out with at Harborview today? We saw a case of this, actually. So let's launch the poll. What's the most likely diagnosis? So we've got 6 responses so far. 13, so METS, angioblastoma, arachnoid cyst, or ADEM. And we've got 19 out of 42 people. Okay, we've got half. I guess half is good enough. Now, can you see the poll as it's in progress? Or do I have to end it for you to see it?
I believe you have to end it.
Have to end it to see it? Okay. So very good. Almost everyone picked angioblastoma. And we can just go back to make sure that everybody is on the same page. So, of course, starting with the history, which is usually the most important part anyway, family history of renal cell and a neuro case should tip you off that this might be a case of VHL and hemangioblastoma. So here on the sagittal long TR and short TR images, we can see first of all, up in the cerebellum, this high signal lesion with these flow voids at the periphery. And then similarly in the spine, we see this area of high signal, which is probably a combination of edema as well as syringohydromyelia, and then low signal, some of which may be flow voids, some of which possibly could be hemorrhage. And then just on the axial image, we see the long TRT2 weighted images with this cystic appearing lesion with the probable mural nodule and some edema associated with it. And on the second case, we see these nodular areas, multiple nodular areas of enhancement, and then high signal within the cord as well. Again, probably representing syringohydromyelia associated with these multiple nodular hemangioblastomas. So, question 2 regarding hemangioblastomas, which of the following are not true? Relaunching, poll will clear. Okay. So, which is not true? The location is intradural, intramedullary. Tumors arise along the peel surface. They're frequently multiple. 80% have VHL, or 80% of VHL cases have spinal hemangioblastoma. Don't you hate these questions? So 9, 10. Getting close. Okay, we're halfway there. And we'll end the poll. And it's pretty evenly split between 80% of patients with spinal hemangioblastomas have VHL versus 80% of VHL cases have spinal hemangioblastoma. I know you're dying to know what the answer is. So 80% of cases, 80% of patients with spinal hemangioblastomas have VHL. So if you've got spinal hemangioblastomas, likely that you got VHL, as opposed to the minority of patients with VHL actually have hemangioblastomas. Much more common to have hemangioblastomas in the posterior fossa than it is in the spine if you've got VHL. So moving on to case 2. And let me move this out of the way. 37-year-old female, gradually increasing myelopathic symptoms, leg weakness, upper motor neuron symptoms. And we've got a series of sagittal T2 weighted images, and on the far right, a sagittal T1 weighted image. Let you gaze at that for a little bit. Axial images associated with this case. Again, these are axial long TR images or T2 weighted images. CSF is bright, cord is iso-intense. You can see the anatomy at multiple different levels. Okay, so what's the most likely diagnosis? That's hemangioblastoma, arachnoid cyst, or ventral dural defects. Let's relaunch that poll. And wait till we get till half. And I see somebody picked 5. There's always one in the crowd. And we're at 20. We need one more. One more brave soul voting. Excellent. We're up to 23. I will end the poll. And so, again, reasonably closely split between arachnoid cyst and a ventral dural defect. sort of like Georgia split as opposed to Michigan split. And so the answer here is arachnoid cyst. So let's just go back and take a little look at these images here. And what we see is that you see the cord, which is actually deviated posteriorly, and it's sort of plastered against the posterior elements of the spine. And then you have this high signal material, CSF signal intensity anterior to the cord. If this were a ventral dural defect, that's a defect in the dura that is anterior or ventrally. And so you'd actually see the cord deviated anteriorly and it herniates anteriorly. And so this could potentially, I guess, be a dorsal dural defect, but not a ventral dural defect. And you actually get a hint that there's a membrane here which separates the subarachnoid space, or the CSF, from this arachnoid cyst that sits anterior to the cord. You can see this probably a little bit better here on the axial images, where you see the cord pushed posteriorly here. And maybe at this highest level, you get a good feeling for arachnoid cyst and CSF that's separated. So arachnoid cyst, most likely. Spinal arachnoid cysts have a female predominance. They usually present with back pain, weakness, and ataxia. Those are common. Let me get rid of the participant list since I don't need it. Most presenting to neurosurgeons are thoracic. It's the most common location for these spinal arachnoid cysts, and usually the treatment is either cyst resection or just fenestration, and the treatment is usually quite effective. So these are, essentially for the most part, curable lesions. Okay, moving on. Case number 3, 45-year-old white female, multiple discrete episodes of back pain, weakness, and paresthesias. So we've got a series of sagittal MR images. On the far left, a long TR image. In the middle, a T1 weighted images without contrast. And on the right, a T1 weighted image with contrast. Let you look at those for a minute. What is the most likely diagnosis? Ooh, I pressed the wrong button. Okay, we'll launch the poll. Everybody should get this one correct. The pressure's on. That's cavernous malformation, meningioma, or giant cell. Wow, look at that. I love whoever's picking number 5. My kind of person. So right, this is a cavernous malformation. Cavernous malformations in the spine look like cavernous malformations in the brain, essentially. So let's go back and take a look at these images. So what is the food descriptor? Actually, I saw it in the case of this also today at Harborview. It wasn't spinal, it was a brain parenchymal cav mal. But the food descriptor for cavernous malformation, popcorn, exactly. I guess it sort of looks like popcorn. Definitely does not look like something I would want to eat. But what's the reason for that heterogeneous appearance? Well, you have the multiple stages of hemorrhage within these cavernous malformations. So they generally ooze blood and have multiple stages of blood over a long period of time. They can have catastrophic bleeding. So that's the risk of them. Most do not. And what is characteristic, at least in the brain and usually in the spine, is because you do get these hemorrhages that occur over a long period of time, you get an accumulation of hemosiderin at the periphery. And so having this hemosiderin ring is characteristic of cavernous malformations. And let's see what else. So which is not true of spinal cavernous malformations? They appear similar to calf mouths in the brain, typical popcorn appearance, complete hemosiderin ring, and they commonly enhance. So we will relaunch. And I guess I just talked about all of this, didn't I? So, and this is a really touchy mouse I have, unfortunately. So excellent. No number 5s on this one. So they do not commonly enhance. And that's one of the things that you'll notice when you're protocoling these studies sometimes, is that the ordering clinician will order follow-up cavernous malformation without and with contrast. There's really no additional diagnostic information that you're going to get by giving contrast, especially in the spine. There is an associated vascular malformation. Let me just make sure that's not, no, it's not part of my next question. With cavernous malformations, does anybody know what that is? You can just put in the chat box or unmute yourselves and shout it out if you want. Another type of vascular entity associated with cavernous malformation, dural venous malformation, or DVAs, dural venous anomaly, exactly right. So they drain normal brain as entities in and of themselves. They do not hemorrhage, but because of the association with cavernous malformations, if you do see hemorrhage adjacent to a DVA, then you have to wonder whether there's potentially a small cavernous malformation that's there, because DVAs don't bleed, and in fact they drain normal brain, and you don't want to resect them, because if they get resected, then you end up with a venous infarct. Okay, next case. 48-year-old white female, chronic headaches, gradually worsening myelopathy. Change it up here, axial CT images as opposed to MR. And just look at this for a minute. It's non-contrast axial CT images, of course. And another case, similar to the first case, different location. This is thoracic, first one obviously cervical. And at the top, we've got CT, and then at the bottom on the left-hand side, we've got sagittal long TR, T2 weighted, and on the right, actually post-GAD, T1 weighted image. Okay, so here, what is the most likely diagnosis? I'm going to try and relaunch this poll and not advance the slide at the same time. Okay, Metz, cavernous malformation, meningioma, or schwannoma. Get your votes in. When we hit half, I'll advance. We're at half. Excellent. So meningioma. Let's just go back and review some of the imaging findings here. So on this axial CT image of the cervical spine, you can see this mass on the right-hand side of the canal here, which has some calcifications associated with it. And looks like and again, it's very hard to see the cord, which is shifted over to the left side. But when we go to the MR, you can see well that again, the cord is displaced, and you actually get widening of the CSF space adjacent to the cord, indicating that is an extramedullary mass. And meningiomas are dural based, right? So they're not extradural, and they will frequently, I mean, they're dural, so not extradural or intradural, but they'll behave like an intradural mass, at least this one is. So it's wide in the CSF space. They may have a dural tail associated with it as well. And so that's a meningioma. Which of the following is true of spinal meningiomas? Usually cervical, calcification is uncommon, usually intradural extramedullary, 66% of spinal canal tumors, or more common in men. And I did not advance the slide by mistake again. See, I can learn. A little slower to respond here. And give it 2 more people. We're getting a nice distribution of answers here. Okay. I'll end the poll. And so most people thought intradural extramedullary. And of course, we went over that. So good. Somebody's listening. Are they usually in the spine, cervical spine? They're actually most commonly in the thoracic spine, even though one of the cases that I showed you was the cervical spine. For most spine lesions, most of the time, except for degenerative stuff, it's in the thoracic spine just because you have more of a thoracic spine than you do of any other part of your spine. Calcification is uncommon. No, we saw in actually both the cases I showed they were partially calcified. Calcification is actually reasonably common in spinal meningiomas. Are they 2/3 of spinal canal tumors? They're not that common, and they're more common in women. There's I think a 2-to-1 or even 3-to-1 predominance in women compared to men. So most meningiomas are iso-intense to the cord, and that's on long TR images, as opposed to schwannomas, which are hyperintense to cord. And this actually is true, something that's useful in the brain as well as the spine. So look at the long TR images and see, is it relatively iso to even somewhat hypointense? Because they can be quite hypointense because of the calcification. But iso-intense to white matter, or are they hyper intense, in which case you're thinking schwannoma, neurofibroma. And again, when we're looking at the IAC or CP angle tumors, where schwannomas are much more common than meningiomas, the signal intensity difference can often be helpful. Next case. I suppose I should be stopping and seeing if anybody has any questions about any of the cases, but you're not a shy crowd, I know. So if you do have questions, feel free to put them in the chat box or unmute yourself, and I'll try and answer them. So next case, 8-year-old girl, 6 months of progressive pain, weakness, and sensory changes. So we got the sagittal T1 post-contrast here, midline and slightly off midline. And not sure where my cursor went. Oh, there we go. Axial images. So axial T1 post-GAD again. let you look at that for a minute. And then different case, same entity. And you can see from the reference there what the entity is. Just realized that. So on the far left, long TR, a TE image, then T1 weighted pre-GAD, and on the far right, T1 weighted post-GAD. And again, T2 weighted on the left, T1 pre, T1 post, and then the axial T1 post. Okay, everybody should get the right answer to this. So is this a MET, ependymoma, meningioma, or pilocytic astrocytoma? Awesome. And 2 people now have picked number 5. You're just pandering. Okay. Excellent. Pilocytic astrocytoma, but you should be asking yourself, why is it not these other things? So let's actually just go back and take a look and make sure that we're all seeing what the findings are. So in this case, the first striking thing is this markedly expanded cord with a central low signal intensity cavity within it, and then irregular nodular enhancement below that, and a second cavity that we see with maybe some nodular enhancement at the inferior margin of that, the caudal margin of that. And then on the axial images, we see this non-enhancing periphery of the cystic mass, and then a central focal area of enhancement that we see. Similarly, on this other case, expansion, we don't have the syringohydromyelia that we did in the other case, but we see some irregular and inhomogeneous high signal on the long TR images, and then some irregular enhancement at the medulla and upper cord. And then down here, again, nodular enhancement with the cystic cavity that's associated with this pilocytic astrocytoma. So which of the following is not true of spinal astrocytomas compared with ependymomas? So that's usually what the differential is, right? Ependymoma versus astrocytoma. So let me try and launch the poll without advancing the slide. There we go. So which is usually not true of an astrocytoma compared with an ependymoma? The astrocytoma is usually longer, more likely to bleed, less sharply marginated, and eccentric rather than central. And not as obvious, these questions. And these are relatively more subtle findings, I would say, and helps push one towards the diagnosis of astrocytoma versus ependymoma. But of course, nothing's 100%. Just need one more person to commit. And I'll close the poll. Excellent. And the poll. So number 4, eccentric rather than central. So which is not true of spinal astrocytomas. So they are not more likely to bleed. So ependymomas, in fact, one of the characteristic things about ependymomas is that they're more heterogeneous in signal generally than astrocytomas. And that is in large part because they're more likely to have hemorrhage within them, and more likely to have hemorrhage that accumulates at one end of the tumor or the other. Astrocytomas are usually larger lesions. They're very slow growing lesions in general, and so are probably more likely to be asymptomatic for a longer period of time. They're infiltrative tumors, and so less sharply marginated. Usually, ependymomas are more likely to have a complete resection than astrocytomas. And so again, that goes along with the astrocytoma, even though it's pilocytic astrocytoma, being less sharply marginated. Eccentric rather than central. So it's the ependymomas, and this is best appreciated on axial images, are more likely to be eccentric. Thank you. So classic appearance of the pilocytic astrocytoma is cyst with a mural nodule that's enhancing. And this cap sign, which is hemorrhage, old hemorrhage, at one of the end of the tumor is again more likely to be seen with an ependymoma because they're more likely to hemorrhage than astrocytomas. Okay, moving on. 40-year-old white female, upper extremity numbness and tingling, progressive for a month. I don't even have to show you the images, right? You already know what the diagnosis is likely to be, but I'll show you the images anyway. So on the left is a T2 weighted image. The middle is should be a proton density weighted image, and on the far right again is a T2 weighted image. And I need to replace these images because they really are terrible, aren't they? Sort of grainy, low signal. But you can see where the cord is and an abnormality within the cord. Okay, so most likely diagnosis here. No tricks, nothing hard. So is this Mets ependymoma MS or pilocytic astrocytoma? Excellent. 13 out of 40, 32% have voted. I'm going to get at least up to Washington state standards, which I think wasn't that 90%, over 90% in this last election. 5 more people to vote. Come on, you can do it. There we go. That's it. Vote for number 5 if you must. 3 more people. 2 more people. 1 person. Excellent. Thank you. Okay. So we'll end the poll. And of course, this is, we have not given you the answer yet. What additional study do you want? You can put it in the chat box, or you can shout it out. Or MR the brain, ask and ye shall receive. So characteristic pattern of demyelinating disease in the brain, periventricular white matter, high signal. And of course that was MS. And I don't know why I didn't show you the answer to that slide, but demyelinating disease, clearly. Okay, next case, 60-year-old white female, back pain, progressive bilateral lower extremity weakness. On the left, long TR image. On the right, short TR, and then on the far right, I'm sorry, in the middle of the short TR image, and then on the far right, post-GAD T1 weighted image. And Most likely diagnosis in this case. We'll relaunch the poll. Continue. So there was a question in the chat, does spine MS mean you should already have plaques in the brain while you're voting on this one? So not necessarily, but you should always look for it because you may well, it's much more common to have demyelinating changes in the brain than in the spine. But of course, with neuromyelitis optica or Devick's syndrome, where you might just have ophthalmic changes and spinal cord abnormality, you may not get demyelinating changes in the brain. So you don't have to have them, but if you do see something that you think is a demyelinating plaque in the spine, you should always look in the brain. So we are at 18 over 40 or 45%. 2 more people to vote for this next case. 2 more brave souls sitting in front of their computer, willing to choose between a MET and ependymoma, meningioma, or pilocytic astrocytoma. 1 more person. Excellent, thank you. We'll end the poll. And so most people correctly thought ependymoma. And next question about ependymomas, which of the following is not true of ependymomas? And we've gone over some of this. So usually heterogeneous signal, more likely to bleed than a pilocytic astrocytoma, usually sharply marginated, most common cord tumor, or myxopapillary variety common throughout the cord, which is not true. Let me see if I can start the poll, relaunch the poll. And here there actually is a 5th choice that you can choose. So we talked about heterogeneity of signal compared to astrocytomas. And we talked about propensity for bleeding. And we talked about margination. We didn't talk about which are the more common tumor. And we didn't talk about the myxopapillary variety. We need 1 more person to vote. Because we're at 47%. There we go. And I need to end the poll. And survey says the myxopapillary variety is common throughout the cord. The myxopapillary variety is most common at the phylum terminale, so at the very bottom of the cord. But all of the rest of those are true, as we went over most of them, except that it is the most common cord tumor in most series. It beats out pilocytic astrocytoma. Next case. How are we doing for time? We're doing okay. 49-year-old chronic back pain, history of ESI or epidural steroid injections. Okay. So here we've got an old study. For those of you who don't recognize this, this is actually a photo of a film of MR. And I would have you pay close attention to the levels. So just look at that for a second. And here, next question, most likely diagnosis is METS, ependymoma, meningioma, or arachnoiditis. And so here we're talking about someone who has chronic back pain. And, you know, of course, we do all sorts of things to people who have back pain, including giving them epidural steroid injections, which are not completely benign. I don't know, some of you are probably too young to remember about 10 years ago or so, 9 years ago, there was this compounding pharmacy disaster where it was the steroid was contaminated with a fungus. And so people ended up getting a fungal meningitis that was associated with epidural steroid injections. Horrible outcome. Okay, we are at 20. So everything has consequences. Excellent. This is an example of arachnoiditis, and we can just go back and take a look. And you'll notice that at L4-5, it looks like we have a cord, but we shouldn't have a cord there. And so this is one type of arachnoiditis, which essentially looks like a mass or a pseudomass, where there's just this severe clumping of the nerve roots into this coalescent mass. And you can also get peripherally adherent arachnoiditis, where you have essentially an empty thecal sac and you don't see any nerve roots. Or you can see a nodular type of arachnoiditis, where you'll have very irregular nerve roots that are nodular and adherent in some places and not. So just recognize, be aware of the different manifestations of arachnoiditis. And here they are: clumped roots, peripherally adherent, or soft tissue mass that you can see. We don't see it that often these days. And if we do see arachnoiditis, we generally don't see this very diffuse type of arachnoiditis. We may see more focal arachnoiditis with locally adherent roots, generally adjacent to a level of surgery. And unfortunately, there's no great treatment for arachnoiditis. Case 9. Far left, we have the long TRT images, and on the right, short TRT images. So T1 weighted images on the right without contrast, and long TRT2 weighted images. Let you look at that for a second. Go on to the next series images, same patient. And of course, these are post-GAD T1 weighted images with fat suppression. And probably looked at that long enough. And then some axial images that we can see. And these are long TR images, just showing you the relationship of the mass to the cord. And these are post-GAD axial T1 weighted images. Okay, most likely diagnosis. And I will relaunch the poll. Schwannoma, ependymoma, meningioma, or pilocytic astrocytoma. We've got 12, 14. So it's not so straightforward. Obviously, the first and third ones are extramedullary. The second and fourth ones are intramedullary. We need one more person to vote. Thank you. And I will end the poll. I think I will end the poll. There we go. I'll end the poll. So interesting. Most people picked ependymoma. So just from a test-taking strategy, of course, I've already shown ependymoma. So, and as we just said, ependymomas, like pilocytic astrocytomas, are intramedullary in location, whereas this, and let's go back and see why this is a schwannoma. So I'm just looking at the sagittal. It can be hard to tell whether this is intramedullary or extramedullary, especially when you're just looking at the top. However, when you start to look at the bottom, you see, as we saw in that other case of meningioma, there's widening of the CSF space between the cord and the dura. And so it's being pushed, the cord is being pushed back essentially. And then it's obviously a very heterogeneous mass that we see here. And then on the axial images, and granted, a little bit hard to tell, but I think you really get the suggestion that the cord is pushed in one direction and really flattened by this mass. Although granted, in some areas, it looks like it may be expanded, but I think what you're seeing for the most part is the mass and then the cord being pushed back here. So extramedullary mass, schwannomas. So which of the following is true of schwannomas? Typical location is intradural extramedullary, easily distinguished from neurofibroma, more infiltrative and harder to resect than neurofibromas, usually low signal on T2 weighted images. Well, we've gone over some of this, I know. All right, let's relaunch the poll. And another question from Richa, schwannoma of that size should not extend into the neural foramina, question mark. I don't know what should not. They can do whatever they want to do. So they can grow into the neural foramina, or they can grow predominantly in a caudad cephalad direction. So would you expect it to, would you expect it to give how big it is? Not sure I understand. Oh, would I expect it to grow into the neural foramina given how big it is? Maybe, not necessarily. I've certainly seen, as we've seen here, nerve sheath tumors, which are predominantly not going out the neural foramina and just staying within the spinal canal. So 2 more people commit themselves. It's always good to commit yourself, even if you're wrong. I was just listening to a talk yesterday. I'd rather be wrong and decisive. This was, of course, a talk by a surgeon. There we go. 21 people. I will end the poll. So which of the following is true? Typical location is intradural extramedullary. We just talked about that. So yeah, that is the typical location, although they don't have to be, of course. And as Richa was discussing, they can certainly go extradurally or be predominantly extradural, if they're involving the nerve roots. And they can actually invade the cord as well. And so these are typical or frequently transcompartmental tumors, but if they're any place in one particular, it's typically intradural extramedullary. They are not easily distinguished from neurofibromas, and it's for that reason that we just call them nerve sheath tumors for the most part. However, on microscopy, it's important to realize that they're more infiltrative and much harder to resect that neurofibromas are, as opposed to schwannomas. And years ago, when we had a peripheral nerve surgeon, a neurosurgeon who was a peripheral nerve expert, Michelle Cleo, we used to do fairly high resolution MR neurography of these tumors to try and distinguish neurofibromas from schwannomas. And if you do the very high resolution imaging, you can actually see that the schwannomas are often eccentric to where the nerve bundle is traveling, and so can be often peeled off the nerve, whereas the neurofibromas are completely intertwined. with the native nerves, and so much harder to resect. And then the last point about usually low signal on T2 weighted images, as we discussed when we were talking about meningiomas, usually these nerve sheath tumors are high signal on the long TR images. So here's an example of a neurofibroma as opposed to a schwannoma. And, again, you get probably best on this sagittal short TR image, the indication that it is extramedullary, and so the cord is being deviated posteriorly here, and you get a hint of a cleft here in between the cap of the tumor and the cord itself. And these are all intensely enhancing on the post-gadolinium T1 weighted images. And again, on the T2 weighted images, high signal. Axial images probably show better the deviation that you can see of the cord, with the adjacent mass being high signal. Next case, 40-year-old male presented with hemiparesis and loss of proprioception, vibration, contralateral pain, and temperature loss. And here is sagittal T1 weighted images. A little bit grainy, but you can see the findings here. And got to remember to get rid of the titles of these references. But a nice example of a T2 weighted image. And this is post-op that you can see here on the right. So nobody should get this wrong. So this is ventral dural defect with cord herniation, arachnoid cyst with cord displacement, meningioma, or neurofibroma. Excellent. And that's 21. And there's my arrow and the pole. And it's the classic examples of ventral dural defect with cord herniation. And we'll just go back to the images and think back to that arachnoid cyst example where you had gradual displacement of the cord posteriorly. So here you have this relatively acutely angulated displacement of the cord ventrally. And what's happening is the cord is herniating through this defect and causing a Brown-Séquard type syndrome, and has this sort of classic appearance, which, thinking about it, this was way underdiagnosed prior to being able to do MR, just because it wasn't appreciated how common this entity could be. It's definitely not common, but I've probably seen over, I don't know, the last 10 years, a half dozen cases of this. So it's not, it's not unheard of and something you should keep your eye open to recognize. Okay, I think that just about does it. Anybody have any closing questions? If not, thank you so much for your attention. Hopefully this was fun and entertaining and you learned something. And Marcus, I don't know if I quit out of the Zoom, if that will cause, did you make me presenter?
Yes, I can end it here for everyone.
Okay, very good. Thanks. Bye-bye.
Thank you.